Aortic regurgitation is defined as presence of diastolic incompetence of the aortic valve with subsequent regurgitation of blood back from the aorta into the left ventricle. What are the pathophysiological features in chronic aortic regurgitation? Aortic regurgitation is characterized by combined volume and pressure overload, which results in higher diastolic stress in the left ventricle, and consequently left ventricle needs to inject a larger bolus of blood into the aorta over the same duration of systole, which leads to increased systolic pressure and, according to our Laplace law, increased wall stress. So diastolic regurgitation results into increase in LV volume, increase in stroke volume, decrease in aortic diastolic pressure, and decrease in effective stroke volume. This produces usually fatigue in the patient. Increased LV volume leads to increase in LV mass, which is mostly eccentric left ventricle hypertrophy, leading to LV dysfunction, increase in LVDP producing dyspnea. And increased stroke volume ultimately leads to increased systolic pressure, increase in myocardial oxygen consumption, and of course decreased diastolic time, and myocardial supply is decreased and ultimately leading to LV failure. So coming back to the anatomy of aortic valve. Aortic valve is made up of three cusps, as we already know: non-coronary, right coronary, and left coronary. And the non-coronary shares the annulus with the anterior mitral leaflets. So this helps us to actually revisit the anatomy. Anatomy is main thing in studying the aortic regurgitation, because ultimately it will lead to the finding the etiology of AR. AR based on etiology is classified into primary, or when the regurgitation is mainly the result of structural leaflet deformity, or it is secondary when regurgitation is from the root and ascending aortic dilatation in presence of structurally normal leaflets. So common causes are degenerative bicuspid aortic valve, RHD, endocarditis, traumatic injuries, radiation-induced valve disease, inflammatory disorders. And common of secondary AR are aortic dissection, aortic aneurysm, Marfan's, aortitis, syphilitic, aortic ectasia. Now, general principles which we follow in AR assessment, they are: evaluate the severity of regurgitation, mechanism of regurgitation, the hemodynamic consequences on left ventricle, associated valve disease, combination of valve AS-AR, and need for any surgery or only follow-up. Mechanism of aortic regurgitation is important to understand because it ultimately influences the event-free survival. It is best with the worst survival is with type 3, which we'll discuss, and the best is with type 1 and simple single jet type 2 lesions. Also, calcification of aortic leaflets has to be taken because to see for the chances of a durable repair. So the new classification in aortic regurgitation is based on the type 1, 2 and 3. Type 1 is further subdivided, as we can see here. The type 1A is basically dependent on the root dilatation, and type 1B is again aortic sinus dilatation. Type 1C is annular dilatation, and type 1D is fenestration of leaflets. So this is it's a good classification based basically on the etiology, and helps us for the deciding the surgical repair. And type 2 and 3 mostly assessed by TE. Type 2 is presented with the leaflet prolapse, and type 3 is deficiency of leaflets, usually seen in rheumatic heart disease or sometimes also degenerative. So what is the echocardiography evaluation of the color jet is based on the flow convergence, vena contracta, and jet turbulence. The flow convergence area is just before the leaflets, which we see when there is the convergence of flow. And then the narrowest part as the jet leaves the leaflet is the vena contracta. And of course, then after the jet turbulence, which is assessed, the same thing can be assessed in the short axis view also. So these are the three components in assessment of aortic diastolic regurgitation. So vena contracta basically you have to you can also use this hide color mode is there. When you use the hide color mode, then the color jet is off, and then you can see exactly where the leaflet position is, and then you can again put the color jet and see the vena contracta.
It gives you a very good idea of the size of the hole in the valve. So you have flow coming in like in a tub. First you have acceleration, then you have the hole in the valve, and that's the vena contracta. So vena contracta is simply don't have to remember, it's like a size of the hole in the valve, and then the jet becomes larger. Thank you. Sorry for interruption.
Yes, it's the narrowest portion which we have to see basically. So according to this, so we have to see for classification, mild, moderate, severe classification, we have to see three parameters: structural parameters, qualitative parameters, and semi-quantitative and quantitative. So in this way, if we go, we can easily classify the AR jet and into mild, moderate, severe. So starting with the these parameter jet width and LVOT diameter. So looking at the parasternal long axis or short axis view, we can see the jet width and compare it with the width of the LVOT. And as well as if we can trace the whole area, we can trace the annular area and we can measure this. So here we have done a measurement where we have found the Vinogram data showing this jet width showing or occupying 40% of LVOT. That was around mild to moderate AOT regurgitation was there. So this is the mild, moderate, severe parameters, 25%, 25 to 40, and sometimes moderate to severe, 40 to 60, and more than 65. Then again, what are the pitfalls? If we measure too far down the LVOT, we have low Nyquist limits, we have excessive color Doppler gains, or in case of eccentric origin jets or eccentric directed jets, and also variation of flow width and blood pressure. They are important parameters before measuring, we have to check. Then semi-quantitative, just as we told, jet area versus aortic root area. This is the one. Same excessive gains, multiple jets, variation of flow, blood pressure dependent. This is the pitfalls which we see in these cases.
It might be good to interrupt so that it's easy to understand. The short axis view is not really that reliable because the heart is moving, So you want to, when you look at the vena contracta, the short axis, you can actually trace the area of the vena contracta. But the heart is moving all the time. So therefore, you can be at the area of the vena contracta, you can be lower down or you can be higher up near the full acceleration. So short axis is not as good as the long axis, Yeah.
Definitely. So another important thing is to see by continuous wave Doppler a faint signal versus a bright signal of the regurgitation jet. A faint signal usually tells us that it is a faint Doppler signal should be a mild AR, but a severe or moderate AR has a dense signal. This is also a good point which can help us. Then the deceleration slope. Deceleration slope is a continuous wave Doppler slope which is a function of the pressure equilibration rate between the aorta and the left ventricle in diastole. So these are the mild, moderate and severe example. As we go down, there is a deceleration slope is actually coming down. So this is how we have to see. And then same with the pressure half time. Pressure half time decreases as the AR decreases severe. Then very important surrogate point is the diastolic reversal in the suprasternal view in the descending aorta. This is measured by a pulse wave Doppler signal in the proximal descending aorta. If the backward flow, as we can see here, if the backward flow persists throughout diastole and has a cutoff of value more than 20 centimeters per second, it is indicative usually of severe aortic regurgitation.
Yeah, here also, I think you can standardize this by putting your pulse Doppler. First of all, always put the color Doppler on. See, the reason to go for the suprasternal view is sometimes there is vegetation on the aortic valve, and you cannot really measure where exactly the vena contracta is, where the jet width is. You cannot measure it very easily. So, or if there is the aortic regurgitation severe, you want to be very sure, doubly sure. So then you go in the suprasternal view, and there you place your Doppler signal volume at the isthmus, which is the junction of the arch of the aorta. If you want to point out, at the junction of the arch of the aorta with the descending aorta, right there where you got the initially, right that point. So you can first of all always put the color Doppler, because you can put the color Doppler outside the flow and you will not get any backflow. So turn the color Doppler on, like he has turned there. You see the red flow signals, and then you place your Doppler sample volume at the junction of the arch with the descending aorta on the top, a little bit on the top, a little bit higher up. No. Show
Yes.
the genu,
Yes.
the isthmus right there. So you place it exactly there. You standardize it. So there, if you see a lot of backflow and it is pan-diastolic, that confirms that the patient has got severe aortic regurgitation.
Yes. And then the Doppler signal we can see.
Right.
So, yes. So this can, but the differential is that this same flow can be seen in large PDA or reduced aortic compliance in the elderly, or any AV fistula, RSOV, or when there is aortic dissection with diastolic flow in the false lumen. So this is a surrogate parameter, but a good parameter. Then comes the vena contracta, as we described, the narrowest portion of the jet, which is independent of the flow rate, driving pressure, less dependent on technical factors, good at identifying mild or severe AR. Sometimes we have to use 3D vena contracta, which is in case advantages is in case of multiple jets when directions can be measured. This vena contracta method has a disadvantage when there is excessive leaflet calcification and there is shadowing of the ultrasound and there is a momentum loss in the LVOT which overestimates the jet. And we cannot multiply vena contracta in multiple jets. That is underestimation. That is overestimation of this. Then quantitative methods are based on PISA or continuity equation. Through that, the parameters obtained are regurgitant volume, regurgitant fraction in depressed EF, and EROA, effective regurgitant orifice area. So, based on the PISA method, we usually take the 5-chamber view where we get a proximal isovolumic hemispheric shell, and then we measure the radius and we use the 2 pi r square equation. So this is the example where we sometimes parasternal long view tilted, we can see the proximal isovelocity surface area, and then we measure the radius here. And or if we can take the apical 5-chamber view, we can take the radius here, and then we have to take the continuous wave Doppler and trace the whole jet. And this gives us on the base of aliasing velocity, we get the EROA, which is effective regurgitant orifice area. That is, in this equation, it is 2 pi r square multiplied by aliasing velocity divided by the peak velocity. So this gives us the EROA. EROA, when multiplied by the velocity time integral of the regurgitation jet, will give us the regurgitation volume, that is 82 ml in this equation. Same thing can be used by using end diastolic volume and systolic volume, or by measuring the stroke volume at the LVOT. And this can also give us the stroke volume, and then stroke volume helps us getting the regurgitation fraction. So 3D echo and contrast echo can be helpful in this measurement because they measure LV volumes. They help us in taking good LV volumes, as well as in taking the LVOT in 3D is more beneficial because of in many studies they have shown that it is not an actual sphere, it can be oval shaped LVOT in some patients. So there it may be helpful measurement to measure this parameter. And then it is the AR can be divided into mild, moderate, severe based on these values, and this is how we can classify mild, moderate, severe. This is the beneficial of quantification is it correlates with the CMR volumetrics. Multiple jets, there is no problem, and spectral flow is always better than the color Doppler. So according to guidelines, this is the chronic AR which has been divided, whether it measures what we measure quantitatively is basically the intermediate values of the AR. Mild AR is simple, severe AR is also very clear cut, but this is the intermediate values where we have to measure the quantitation methods are used. Points to remember always that color flow mapping is not equivalent to angiography. Regurgitation depth is not equal to regurgitation volume, but it only depicts the flow disturbance. Jet direction is important variable which can lead to underestimation or overestimation of AR. Central jets usually expand as it traverses from the regurgitation orifice towards the LV, and eccentric jet due to Coanda effect show 50% reduction in the total effective regurgitation area. And we also have to remember that the AR in normal functioning LV depends on EROA, mean regurgitation velocity, which is usually high, and duration of diastole. So, if a patient is having tachycardia, we will have a very small jet, and this is very important measures which we should take in mind before measuring the AR. So, the flow chart ultimately for evaluation is do a transthoracic echo, understand the anatomy, mechanism of AR and the severity, check on the LV dimension and functions. If there is aortic dilatation and the patient's age is above 50, do a CT for accurate definition of thoracic aorta as well as for calcification. If echocardiogram findings are not conclusive somehow, and then you can directly proceed to TE. If the patient is a bit unstable for MRI, you can proceed for TE and understand the mechanism and severity, or you can directly go for CMR. So, this was one example I wanted to show. Can you play the video? So this is one example we had 5 days back. Young patient having 5 months of fever and came with acute onset dyspnea. So we did transparency echo in the emergency, and what we found was that transparency was unable to get the jet. Are you able to play? No problem. So we were just getting flow turbulence in all the views, short axis, long axis, all views. But again, suprasternal view helped us in picking up the diastolic reversal. This indicated that patient was definitely having some severe AR because the anatomy of aortic valve, as we had seen in the earlier picture, was quite a calcified valve. And then we did
Rohit, if you go to the previous slide, just show.
Yes,
because your basics. So here you can see that the diastolic flow is very prominent and pan-diastolic, right from the beginning to the end of diastolic. So if you see that, you know there is severe aortic regurg. I mean, there are some problems like you can have a kidney shunt, and PDA, but otherwise, in normal, most patients, this will be severe AR. And if you can't get the suprasternal view, you can go for abdominal aorta. After you examine the IVC, go to the abdominal aorta, and there also, if you see prominent backflow, that will go for severe AR. Because there's sometimes bandages on the chest, on the neck, after surgery. Okay? Thanks.
So in this patient, the only transparency finding which was indicative of AR was this, because in other views, we were only getting jet turbulence. So we did a bedside transesophageal echo. We could find a vegetation flail with the eccentric AR jet. This is a esophageal view. And the transgastric view, the AR jet was completely delineated. It was a severe AR. The patient had dilated LV, patient had abnormal anatomy of the aortic valve, but somehow we were not able to make any transvarsal view. Then transesophageal echo, bedside was the only helpful investigation. Patient could not be shifted for any CT or MRI. So these are the some. Then MRI is now playing a good complementary role in evaluation of AR. MRI helps in tissue characterization, as we can see here. This is a AR jet in MRI, and then tissue characterization in terms of fibrosis, T1 mapping, and then easily we can measure the forward and the regurgitation flow here, and which can calculate the regurgitant volume. So it is definitely becoming a complementary modality in cases where echo is not able to give us the full answers. CT can be helpful in planning for the aortic repair or in case of aortic dilatation. So these are the complementary modalities which we can use now. And latest is that the strain echo has been tried in some patients with chronic AR for early referral to surgery. In that, some studies are finding that if the global longitudinal strain is less than 18%, then early referral can be advocated to some people with severe AR. Thank you so much.